Okay. I'm extremely thankful to the organizers and especially the Tamil Nadu and Pondicherry chapter of IPS. It's a privilege and honor to be here because of, not just because I've been invited for an oration, but it is on the platform where I don't think any pathologist has been before. I'm in in a congregation of pediatric surgeons, and really extremely thankful for Muhammad Yusuf Oration, and thankful for Dr. Abul Hassan. Mr. Muhammad Yusuf is his father, and Dr. Hassan has initiated this oration ever since the inception of this society. And what I have learned about Mr. Yusuf is very impressive. First of all, when I heard about it, I thought he was a medical doctor, but then I realized that no, Mr. Yusuf born in Tiruvar, and he was an agriculturist by profession. He developed business in Malaysia. He was an educationist, philanthropist, and social activist, both in Malaysia and India. So quite a feat for an agriculturist who was not even based in India, but in Malaysia, and developed so many philanthropic associations with India. He was a founder, president of Indian People's Forum in Malaysia, and he dedicated his life for education and empowerment of women in Muslim society. So, it is such an impressive work done, and in his era. So, Dr. Hassan, really thankful for you to remember in this way of oration. And again, thanks for this honor that has been given to me. I'm acutely aware of the fact that I am the odd one out in this crowd. I don't think there is any other pathologist here. And a pediatric oncopathologist, that's for sure. It's a super specialization. But through this honor and being on this dais for a few minutes, it's giving me an immense opportunity to project what a pathologist does, what is the pathologist work, and how it is integrated into the clinical practice. You must have seen, like everywhere, it is like one line is quoted about pathology diagnosis. And the pathologist remains unseen most of the times. I don't even know how often a dialogue is made with the pathologist. So I really take this opportunity to project that as to what really happens, especially now on this occasion through the Wilms tumor management. Let me go back to many years ago, like when it's an ancient era, 1994, when I had recently shifted to Mumbai, and I started my lecturership in JJ Hospital, Mumbai. I had no idea how Mumbai was. It was my first visit to Mumbai. And then this is an iconic image or iconic site in Department of Pathology at JJ Hospital. It stands right at the entrance, and that is where the museum is of JJ Hospital, where you can see incredible collection of specimens. And that, when I entered JJ Hospital, it really impressed me, and that image is still into my mind. And it says, "Genius alone lives, everything else perishes." So that was my first glimpse, or the first introduction to pediatric pathology, where Professor Grace DeCosta, who was a senior pathologist, was immensely interested in pediatric pathology. Till then, I had no idea what pediatric pathology really means. I had just passed out MD from GMC Nagpur, and I had never seen small fetuses being autopsied, the organs, and it was my first glimpse into quite an unknown world. It was so fascinating. It gave me an introduction to an embryonic development and its abnormalities as well. So that's what it. And then quite coincidentally, well, not quite coincidentally here in this instance, we moved to the UK, and I spent 6 months just as an observer in York Hill Children's Hospital, Glasgow, with Dr. Howardson and Dr. Patrick. And this 6 months, although I did a few things hands-on, but this opened a whole new world, even beyond what I saw in JJ Hospital, into pediatric pathology. This was a standalone pediatric pathology hospital, and it had an immense workload of autopsies as well as surgical pathology. So here the autopsies were performed on small fetuses as small as 8 weeks. Then we came across various cardiac anomalies, different syndromes, and then the surgical pathologies of variety of tumors which I had even not heard of, Hirschsprung's disease, and so on, motility disorders. So I heard it a lot, and this was 6 months before I started my residency in the UK, and never did I know, I didn't even think that my career would happen in pediatric oncopathology. Later on, after 6 years in 2001, when I joined Tata Memorial Hospital, and here I began my journey in pediatric, exclusively in pediatric oncopathology. So whatever short experiences of autopsies or other diseases I had, they are kind of faded now, and I am into hardcore oncopathology. And when I joined Tata Hospital in 2001, I realized one thing, that this place is really, really advanced for the Indian scenario in many, many aspects. And the first aspect, especially when it came to pediatric solid tumor group, was the concept of a multidisciplinary meeting and integrated approach, which was spearheaded by Dr. Poorna Kurkure. I don't know if some of you surely know her. She is Dr. Poorna Kurkure. She knew the concept of multidisciplinary meeting and integrated approach in the solid tumor, in tumor management as a whole. Why I'm saying that and why I'm highlighted is that Tata Hospital went into the DMG, the disease management group culture, much later, maybe a decade later. But then Dr. Poorna Kurkure was implementing this in her clinics. I still remember that phone call would come if you don't attend a single JC. We used to meet twice a week. And if you don't attend that JC, she used to call, Mukta, where are you? And I used to dread that phone call. And we all are so disciplined even today that we no longer wait for any phone calls, but we attend those JCs twice a week. Everybody, we are there in the clinic. And that is how the pathologist in Tata Hospital is never invisible. We have to be there. It's not an excuse not to go for the meetings. And this is how the constitution of our pediatric solid tumor disease management group is. We have everybody on board, of course, the oncologists, the surgeons, the radiation oncologist. In this box, I'm here along with my expertise in histopathology as well as in molecular pathology. Then we have radiology and lot of ancillary services, opthan, pal care, physiotherapy, anesthesia, and that is what constitutes the pediatric solid tumor DMG in Tata Hospital. So we treat all children with pediatric solid tumors from infants to 15 years of age. And we do not, this particular pediatric solid tumor doesn't exclude the brain and the bone tumors, although I must say that the medical oncologists are also involved in the care of neural, in the neuro DMG. Whatever I'm going to say in next few minutes is a culmination of the experiences through the years, through the management of these patients and the expertise and the knowledge of the members of pediatric disease management groups. So we learn from each other, and it's each encounter, each JC is an enriching experience through the patients and through the entire team. It's a continuous interaction. We keep on learning. So as I said, we have joint clinics twice a week, academic meetings which happen monthly, and we have yearly workshops as well. I'm stressing that because this concept, especially I'm seeing a lot of young people here, this concept of an teamwork goes beyond anything when it comes to tumor management. This is how our workload is in pediatrics. So we see around 650 to 700 new cases every year, out of which renal tumors range between, again, around 60, 65. These are the new cases that we see. The highest of the tumors that we see are sarcomas, but this includes all sarcomas, rhabdomyosarcomas, Ewing sarcomas, the non-rhabdomyosarcomas, etc. So a huge workload. Coming to today's topic that I wish to discuss is Wilms tumor traversing along the transatlantic bridge. And what is this bridge and how do we really traverse? Wilms tumor is a commonest pediatric renal tumor. It is one of the success stories of pediatric oncology. They have long-term survival above 90% for localized disease and 75% for the metastatic tumors. And it is a result of collaborative effort between pediatric oncologists, specialist surgeons, radiologists, pathologists, and radiation oncologists. It is very well known that geographically and historically, there are two approaches to management of Wilms tumor. A SIOP approach which promotes the biopsy, we'll talk about this, then chemotherapy in all children, surgery with few exceptions, surgery in all, followed by risk stratification and the adjuvant therapy. On the other hand, the Children's Oncology Group, the Northern American group, promotes upfront surgery, no biopsy, no pre-op chemotherapy, except in obviously inoperable tumors and bilateral tumors, followed by risk stratification and adjuvant therapy. Now, both of these approaches across the two ends of the Atlantic Ocean have their staunch philosophies and have the very strong arguments in support of those philosophies. SIOP approach tells us that the giving preoperative chemotherapy reduces complications of surgery and tumor spillage, and leading to easier surgical removal of a shrunken tumor. Then it induces a better stage. Micrometastases are treated as early as possible. We can measure response to treatment quite objectively and thus can individualize post-operative treatment stratification. There is less frequency of lymph node involvement. And this is the paper by Dr. Vijanik, where he has studied the effect of preoperative chemotherapy on histological subtyping and staging in Wilms tumor through the UKCCHG group. And he has said that there is a 50% reduced proportion of blastomal and mixed type Wilms tumor when treated with chemotherapy and significant reduction in stage 3. So this in nutshell is a philosophy and this concept of SIOP. On the concept of the biopsy now, let's just, we have spoken in each conference of pediatric oncology, we have spent a lot of time discussing about the biopsy. COG advises no biopsy, and if we perform a biopsy, it straight away renders a Wilms tumor as stage 3. However, core biopsy used to be recommended by SIOP, which was followed by preoperative chemotherapy by default. The results have shown very little morbidity in terms of the technical aspects of a biopsy procedure. Even needle track recurrences are less than 0.5%. There is no effect on final tumor staging. It was an opportunity to obtain tumor tissue which was not treated by chemotherapy. It does identify benign tumors and avoid unnecessary chemotherapy. So the last sentence, to identify the benign tumors and avoid unnecessary chemotherapy, was the major or the dominant purpose why biopsy was performed by SIOP before chemotherapy. However, the SIOP itself has revised its own national guidelines very recently, and they have reviewed the diagnostic accuracy and clinical utility of pediatric renal tumor biopsies. And what they have demonstrated is that biopsy, the purpose for which it was done, is actually less effective in identifying non-Wilms tumor than the Wilms tumor. then it rarely changed the management in younger children. So they have now revised the policy as to no biopsies necessary for children aged 6 months to 10 years who have typical clinical and imaging presentation for Wilms tumor. And biopsy should be reserved in SIOP protocol for children over 10 years of age, because then the different types of diagnosis start coming in, like translocation associated RCCs and some other tumors as well. And in younger children with clinical or radiological features which are inconsistent with Wilms tumor. So only these children should undergo biopsy. Now, the COG approach tells you that the upfront surgery gives a precise assessment of tumor extent and histology to chemotherapy. It allows immediate histologic diagnosis, collection of biological materials which are unaltered by therapy, and it gives you an insight into the inherent invasiveness and aggressiveness of the tumor. Having said that, the COG approach is definitely fraught with higher rupture rates than the NWTA studies, and they range from 33% in the earlier studies, but now coming to 11% in the latest studies. The tumor rupture obviously appraises the disease stage to stage 3, and a significant augmentation of therapy, especially in terms of radiotherapy, is indicated. Now the issue is, we already know about these staunch philosophies of COG and SIOP. The question is, what does the rest of the world do? And that incorporates us as well in India. What do we do? And we, outside the Europe and North America, both the approaches have been used extempore. There is a lack of consensus for the timing of surgery, so it is a case-based or the tailor-made approach that we usually follow, and that's what it means when I say that we in India and also outside the COG and SIOP, we really traverse along the transatlantic bridge when it comes to philosophy of Wilms tumor. And what is the Indian approach? What do? We try to achieve the best of both worlds. And definitely tailor-made patient selection. But the question is that, who is this tailor? Yeah, what are our approaches to make these selections? That is the key question. And by whatever means, by maybe the natural selection of the tumors, higher stage of the tumors, we do lean more towards the SIOP practices. That happens by default. But there have been certain criteria which are already laid down as far as the patient selection for surgery goes. The UK W3 trial uses radiological criteria for inoperability, which are tumor extension to the IVC and non-visibility of the hilum. Similarly, COG also uses radiology criteria of tumor thrombus up to the level of hepatic veins and contiguous involvement of adjacent organs. But in both the SIOP as well as in COG, the surgeon's assessment, like a large fixed tumor, is also added, and it remained there. I think it is still used for patient selection for surgery. Now, other risk factors for tumor spillage are identified, which are tumor size more than 10 to 12 centimeters, large tumor volume more than 1000 cc's, and tumor to abdomen ratio, displacement of great vessels, and contralateral extension. So these, in spite of these parameters, there is definitely a subjectivity to the selection of patients as far as the patient goes for surgery or the timing of the surgery. So I'll just project an attempt which was made in TMH. This is our data which Dr. Sajid Qureshi has collated and published. It's in public domain, wherein we tried to have a customized approach for upfront or delayed resection using radiology criteria in unilateral non-metastatic pediatric renal tumors. It was a prospective study of 89 patients. So it was all about selecting wisely and objectively, where what we did was, this was planned to optimally leverage the benefits of two approaches by selecting the patient for upfront versus delayed surgery by means of objective radiology criteria only. So this is the catch. It is only radiology criteria. And then the image-based high-risk radiology features were devised and they were utilized, and quantifiable characteristics were used to define the stage distribution, complications, and also outcomes of treatment in the two groups. Surgeon's assessment was not considered. This again is the key, surgeon's assessment, and you must appreciate Dr. Sajid's courage and that he actually removed his own assessment and allowed only radiology criteria to be used for selecting these patients. What this study actually does is, apart from the objective criteria, it also accepts that in India, we have to get the best of the both worlds. We cannot conform ourselves to either SIOP or the COG. And this is our real life scenario, that we have to conform ourselves to both these philosophies. And the issue is that how do you select which one goes for what? And this study of ours was an attempt towards that objectivity. So these were the high-risk radiology features. So any one of these features, extension of tumor across the midline, suspicion of perinephric spread or adjacent organ infiltration, presence of intravascular thrombus, only even if it was in the renal vein, presence of ureteric extension, extensive retroperitoneal adenopathy, significant nodes that were encasing retroperitoneal vessels. So the presence of even a single feature deemed the tumor unsuitable for upfront surgery. And I will obviously, for a time constraint, not present all the results, but this paper, apart from our aim of objectivity, also gives a very good comparison of the SIOP and the COG philosophies, because both patients are existent in this single study. And if you see histology of this tumor, favorable histology according to COG were seen in all the patients. And as far as the SIOP risk stratification goes, intermediate risk patients were the dominant, with high risk patients following only 14%. And when it comes to stage, the upfront surgery patients predominantly were either stage 1 or stage 2. However, in the delayed surgery, the proportion of the stage 1 and 2 patients were understandably lower. Now, apart from patient selection, a lot happens in Wilms tumor after the surgery is done. And that is the adjuvant therapy in terms of chemotherapy and radiotherapy, and it is based on the risk stratification. And this is the risk stratification. If you look at these parameters very closely, the SIOP and the COG again differ in their philosophy in risk stratification. Although the culmination of risk stratification is obviously to determine whether to give chemotherapy or not and whether to add radiotherapy or not, but the parameters that they both use are also different. The stage and histology is common in both, but the COG adds the LOH1P16Q, age, tumor weight, and lung nodule response in the risk stratification, whereas the SIOP adds response to chemotherapy and tumor volume in addition to stage and histology. So these are the nuances which have to be kept in mind by each person in the team when we are risk stratifying our patients, because they are not uniformly treated according to either of the philosophies. And here comes the pathologist's role here. We need to deal with both types of surgical specimens, and it is extremely complicated due to two different treatment approaches. It is resulting in different methods of staging as well as the risk stratification and different parameters and definitions. So from here on now, I might take you to a little bit into the pathology laboratory and the world under the microscope. The COG protocol is relatively easier because these patients are not treated with chemotherapy, so the histology remains quite unaltered, and the staging system is pretty, it is simpler as compared to the umbrella protocol which is proposed by SIOP, and this demands a lot. It demands a lot out of the pathologist. This is a renal tumor study group of International Society of Paediatric Oncology, the SIOP RTSG, and this has updated guidelines for pathologists for handling and processing of tissue quite recently, and we have been following this. As I said, it is very labor intensive and a lengthy process. The purpose of pathology examination in itself is to give a post-operative histological classification, staging, and treatment stratification. So it is always a combination of gross and microscopic examination, and this process requires a constant dialogue with surgeon. If you are not already into the dialogue, or if you haven't been bothered by the pathologist, that is worrisome, because we bother our surgeons all the time when it comes to staging Wilms tumor, and I'll tell you the reasons why. It actually starts with the history of neoadjuvant chemotherapy. This comes from the clinic, of course. This is hopefully should be there on the electronic medical records, but if this important information is missed, the entire process of staging Wilms tumor just loses its purpose, because it's the assessment, the method of assessment by both the SIOP and the COG are very, very different. Now, I know I'm finding it very courageous of me to tell you this, because I'm the only one standing here from pathology, but I'm telling you to kill that curiosity when it comes to opening these specimens in the operation theater. Wilms tumors are massive tumors most of the times, and whenever we cut the specimen, that capsule which is overlying the tumor retracts. And the assessment of renal capsule is an important anatomical parameter when it comes to staging Wilms tumor. So if that retracted capsule is not traced by the pathologist in an already cut specimen, we just losing the plot here when it comes to staging. So it should never be, the specimen shouldn't ever be opened in the operation theater, and also a message to the pathologist that we are not supposed to handle the kidney as we handle it in other medical diseases. Like we always strip off the kidney's capsule to see how the surface of the kidney is, because that gives quite a valuable information. But this is one exception where the specimen is always kept completely intact. And this is how we process. This is the pathologist den now. A huge Wilms tumor which is distorted. Hilum is almost seen at the inferior part of the kidney. And this is, again, I want to emphasize that the orientation in such distorted specimens is exceedingly important. At least if the hilum can be identified by the surgeons in the operation room, it really is immensely helpful. And we handle the specimen in this way, as I said, quite intact to begin with. We orient the specimen, we take the measurements, and then we make use of the ink quite liberally. You are seeing this tumor for the last time at this moment. The very next moment, it would all be smeared with a black ink. And that black ink serves as a guide or an indicator for the circumferential resection margin, or so called. It's not really a margin. The whole thing is a circumferential resection surface, and that inking of that surface helps us to identify it when the slides come under the microscope. And we open these specimens along the hilar aspect of the kidney. The tumor dimensions are again measured and noted. The tumor volume can be measured at this point. We sample the hilar lymph nodes and they are sent separately, and at this point the entire specimen is fixed in formalin. This is how the Wilms tumor looks like, and the gross findings of the Wilms tumor is it's a well-defined tumor without the infiltrative edges as against the other tumors, rhabdoid tumor. This is one of the rare metanephric adenomas that we had in files. And what we do next is we have to sample the sections the next day, and it is a very, very labor-intensive process. What we do is we take the largest slice of the tumor, we separate it from the rest of the specimens, and we orient it with respect to the hilum, and then each slice is cut in a grid fashion. So coming to the real life specimen, this is how a so-called grid is made. These were multiple parallel sections taken from the Wilms tumor, and we selected the largest slice out of this, and then we had literally made multiple squares out of this, and each of this is numbered from 1 till whatever it goes on to. And each of these are then submitted for histopathology examination, and this particular diagram is replicated onto the paper as well. There should be some, okay. I don't think, okay. So this is replicated on the paper as well, where we draw this and this exactly the same diagram, where we know exactly what is coming from where. I know that these sections 1, 2, 3, 4, 5, 6, 18, 20 are from the circumferential resection margin. The hilum was somewhere here, or if the hilum wasn't there in this particular largest slice of the tumor, we go back to the specimen and sample the hilum separately, because that is where the sinus lies. That is another important parameter for staging. And that is how this is just yet another specimen. Why do we do this such an extensive sampling? Because if you notice, this method gives us an exact location of the, or relation of the tumor with the circumferential resection margin, the relation of the tumor with the renal capsule, with the perinephric fat. And this is precisely the reason I was urging you not to open the specimen, because if this was opened earlier, all these relations would be distorted and lost, affecting final staging. And another reason why we do this such extensive sampling is that we have to detect and subtype the anaplasia. It requires systematic and extensive sampling. Even if grid is not obtained, please ensure that mapping and sampling is performed. And here begins the histologic risk assessment. We have to stage the Wilms tumor based upon different parameters. We have to assess response to chemotherapy. We have to calculate the amount of blastema in the patients who have received chemotherapy. And finally, the most important thing is diagnosis of anaplasia, if it is there or not, and if it is there, is it diffuse or not. So in staging, it begins for the pathologist to understand the anatomy and the surgical anatomy of the kidney, and obviously the surgical, the oncologic principles of surgery as well. And this is the kidney which is very well retained with capsule, perinephric fat, Gerota's fascia, renal sinus, etc. But when it comes to tumor, you also have to understand, like I have learned so much from Dr. Sajid when we were writing the grossing book chapter, which is published by Department of Pathology, Tata Hospital. And to believe me, I was thinking for so many years that Gerota's fascia is the last that you can get in a radical nephrectomy specimen, and that constitutes the circumferential resection margin. But now I have learned that the surgeons also go beyond that fascia, and we can also have the fat or the connective tissue from the pararenal fascias as well, both anterior as well as the retroperitoneal. And it is such an important message for the pathologist to understand that, because the terminologies that we use, the understanding of the resection margins, all that comes and evolves with the constant dialogue that we have with the surgeons. Now, when it comes to the staging, SIOP and COG thankfully don't differ too much, with one resounding exception, is that the COG doesn't allow biopsy. If a biopsy is performed, it is by default a stage 3 tumor. So, as far as stage 1 tumor is concerned, it is completely a pathologist's responsibility, because here the tumors are confined to the kidney, and then we have to look at various parameters. But when it comes to the stage 3, we really require a continuous dialogue with the surgeons. And the definition of stage 3, there are about 8 definitions of stage 3. And it begins with viable tumor at a resection margin. What is a resection margin? If you actually look at the published literature, there is nothing really which specifies what is a resection margin. Apart from the ureteric and the vascular cut margins in the hilum, nobody really talks about the circumferential resection surface. It's not even a margin. Anyway, but we have to address that. Then non-viable tumor at stage 3, abdominal lymph node involvement, presence or absence of tumor rupture. Now this again, I have to stand here and I have to urge the surgeons. Whenever there is a tumor rupture, trust me, when the specimen comes to histopathology dissection table, the site of rupture may not be evident. And as you know, it should not necessarily form a big fat hole that is evident. So when it comes to us, it has to be marked the site of rupture, tumor rupture, as well as the tumor adhesion if at all it was there, or if there were any other structures, like if a colonic mesentery has been resected along with the specimen, if the diaphragm has been resected. Intraoperatively, it's very, very obvious to you because you are dealing with these obvious anatomic structures. But when the specimen comes onto the pathologist table, these means what? Colonic mesentery is what? It's just the fat. Diaphragm, we may not be able to delineate a particular diaphragm. Oh, look, this is diaphragm. It may not happen that way. So unless it is marked very, very specifically and indicated, the pathologist can essentially miss a very important information. So here is the power of the ink, and when I say that, I am not meaning this ink at this time, but this ink. Please indicate the hilum in large tumors which distort the kidney, indicate the site of tumor rupture and adhesions, and if any additional structures are incorporated into the specimen. And this I am quoting verbatim from the SIOP RTSG protocol. What does it say? It says that the finding of viable or non-viable tumor thrombus. So we are talking about tumor thrombus now. If it is bulging at the resection margin of the renal vein or the IVC, it needs to be discussed with the surgeon. And why? Because if the surgeon confirms that they resected the vein away from the thrombus, then protruding thrombus at the vascular resection margin does not mean it is stage 3. And this happens because once the vein is resected, it tends to retract, and we may have a false stage 3. So the intraoperative discussion with the surgeons of intraoperative findings by the pathologist is very, very important, and this is the commonest reason why the phone call goes to the surgeon's office from us. We have also made a small attempt of standardizing lymph node sampling for Wilms tumor, which was a feasibility study with the outcomes, and it is just an attempt again by Dr. Sajid Qureshi, where he has formulated the dissection of the lymph nodes by 5 stations. We got mean 8 lymph nodes and 13% of positivity. So whenever the specimen comes to us, each of these stations are named by the surgeon when the specimen comes to us. Now, chemotherapy-induced changes in Wilms tumor is another histologic assessment that is made. It affects all the 3 components of Wilms tumor, and what we look at are all these chemotherapy-related changes which are inflicted upon the tumor, and we look at whether there are anaplastic foci and the amount of blastema. Right, and this is what I was meaning. This was how the specimen was grossed, and this was it was replicated on the paper, so that when the slides come onto our desk, I am correlating each of this slide with this image, and I know where exactly each of this section coming from. And this goes on for quite some time. It's a very, very intense process, where on each slide we demonstrate what is the percentage of viable tumor, what is the percentage of all 3 components, is there any anaplasia, and then the average is given in all the slides, and it is culminated in response assessment in this way, which is again according to the SIOP guidelines. Post-chemotherapy blastomal predominant Wilms tumor is one of the unfavorable parameters according to SIOP. Along with the anaplastic Wilms tumor again. This is how anaplasia looks at. You have to look at all the slides very carefully to see whether the anaplasia is present or not. If it is there, is it diffuse or is it focal? Stage 1 anaplastic Wilms tumor prognosis is same as stage 1 favorable histology Wilms tumor. So if it is resected completely, we are not worried about stage 1 anaplastic Wilms tumor. But from stage 2 to stage 4 anaplastic Wilms tumor, it diminishes the prognosis quite significantly. It is a marker of resistance to chemotherapy, and the patient requires treatment augmentation. And distinction between focal and diffuse anaplasia is made in COG but not in SIOP. it's the other way around. It's made in SIOP and not in COG. And everything, all of this lot of work that happens in the pathologist's brain then culminates to the risk stratification in this way. When it comes to SIOP, we stratify these tumors as low risk, intermediate risk, and high risk. The low risk Wilms tumors are only CPDNs and completely necrotic Wilms tumor. The intermediate risk tumors form the dominant Wilms tumors in our files, whereas the blastomal type of Wilms tumors and diffuse anaplastic Wilms tumor are the high risk Wilms tumor. On the other hand, COG defines Wilms tumor as focal anaplastic as well as diffuse anaplastic. So any anaplasia in COG is a high risk category. And now this is how the ultimate risk stratification of histopathology is incorporated into both SIOP as well as in COG protocols, and the decisions of chemotherapy, addition of doxo, addition of radiotherapy, very important decisions for the patients are taken at this stage. So it is a balancing act. It begins at the at the surgical level. It continues for the pathologist, it continues for the medical oncs and also the radiation oncologists. So on one hand, we have neoadjuvant chemotherapy advised by SIOP, wherein the pathologist have to give the treatment response, presence or absence of anaplasia, and the blastomal predominance, which affects the adjuvant treatment. Whereas in COG, there is no neoadjuvant chemotherapy. However, the histologic risk stratification still stands. So I must say, when it comes to adjuvant treatment, the surgeons and the pathologists are two very important quality variables. The adequate surgery without tumor rupture, adequate lymph node sampling defines a good surgery, and a good risk stratification and good appropriate accurate staging is the pathologist's responsibility. I must actually finish my, my talk here. But then, are we really done and dusted at this stage? The answer is really no. That's because we are moving towards the molecular biology of Wilms tumor as well, in terms of loss of heterozygosity at 1p and 16q. At this moment, it is incorporated into the risk stratification of the COG, but not in SIOP as of now. But SIOP is proposing its umbrella trial, and it gives a lot of recommendations. There are a lot of pathology aims, biomarker aims, and it tells you, it reinforces the practices of pathology, and it optimizes pathology diagnosis. It recommends rapid central review. I'll come to this factor very soon. And it aims to accurately assess the blastema and of course the staging. But in addition to that, the biomarkers in terms of 1Q gain, which is supposedly a prognostic marker, and the studies are still ongoing. And then they also propose the biobanking aims. Now coming to, Umbrella has definitely proposed its new trial. We are trying to collaborate with Umbrella. It's a very initial phase. Dr. Ramandeep is trying to spearhead along with Dr. Shalini Mishra. It's in its nascent stage, but at this stage, we are really experiencing such big challenges. And these challenges actually begin with the diversity in our clinical practices. Just as I said, the very topic of my talk is like traversing along the transatlantic bridge. So all of us are practicing these two philosophies depending upon what patient fits where the best. I do not say it is wrong. In fact, I think we are getting best of the both worlds. But when we are trying to collaborate with a certain concept, for example, here an umbrella belongs to the SIOP, then these diversity of clinical practices have to be addressed, and they are very difficult to address. It will definitely affect the patient accrual. There is when it comes to pathology, there is no uniformity in the grossing techniques, and it affects appropriate staging. What is the answer to this? And this we see very, very often in our clinics where Wilms tumors patients are referred and we have inadequate staging. it does affect the further management. We err towards over-treating children, which is not really appropriate, but that is what we do, and it is certainly a result of inappropriate staging. Then central pathology review, I mentioned, Umbrella proposes that they have been practicing this quite prolifically, quite extensively for many years, and Gordon Bujanik, the pathologist who deals with Wilms tumor, has been doing this since so many years. But then, do you really think that it is feasible in India? We are a huge country, and this one thing, the central pathology review, we were asked to do this and we simply refused. I said, with the workload that we are already dealing with at TMH, central pathology review coming from all over India is impossible. So we have suggested the incorporation of different regions in India. We can have around four or five or even maybe more centers which are dealing with Wilms tumor, and then incorporate. So central pathology review is not possible. The lack of molecular testing facility in Indian setting is a challenge again. Lack of biobanking facilities is again. What is the answer to this? So as I again said, let us distribute the workload here. Like I am one of the founder members of the Indian Association of Paediatric Pathologists. It is a nascent society, but it has brought together the pathologists on the national level, and we are striving to have a single platform where we talk same language. I am spearheading this pediatric oncopathology ECAS program, which involves the Southeast Asia region. It is a WHO initiative. This also is a platform purely as an educational exercise. It goes beyond the boundaries of India, but again, it can be helpful in making some collaborations. As I said earlier, the Tata Hospital has this grossing book, and this incorporates the grossing techniques of all surgical oncology specimens, the pediatric kidney grossing is one of them. Here is the proforma that we use for pediatric kidney tumor resections. Is different from that of pediatric adult kidneys, and because of the obvious reasons that I just stated. So all of us use these templates for all oncology specimens, pediatric kidney being one of them. So I just highlighted our diversities in practices and its impact on the patients and our own clinical practices. The answer is definitely the education when the challenges are to be concerned. The challenges through NCG, that's the National Cancer Grid, which is a nationwide network which is spearheaded by Tata Hospital. It incorporates more than 200 cancer centers. We are the part of it. It is a great opportunity to have the standardized practices nationwide. So to summarize, each member of the team is involved in Wilms tumor. We have to be aware of our diverse practices which conform to both SIOP and COG principles, and each one of us have to adopt the respective practices. Integrated team approach is the key. So we are striving to get best of both worlds, which to me is actually an added advantage, being not on the either side of the Atlantic. Thank you.
It's really excellent, madam. I'm really amazed how you handled such a high quality content throughout your presentation. It was like reading a full oncology book this 40 minutes time. And another point I like to, I had felt all along your presentation, you said in the beginning, made a remark that you are the only person pathologist. But we had a feeling that more than a pathologist, a pediatric surgeon is delivering this oration. Such a wonderful experience. And definitely I'm sure this your oration talk messages would definitely given help all our friends here who are dealing with the Wilms tumor. You know, it's one of the most common solid tumors, the pediatric age group. Definitely it would help And also you have justified your title that traversing the transatlantic bridge between the SIOP and the COG. Excellent, excellent, very excellent. Thank you very much, madam. Thank you very much.